Welcome to everyone joining the EBRS, UNITAR, and Global Surgery Foundation webinar on COVID and laparoscopic surgery. We are very excited to host this event, and on behalf of the United Nations, we're very excited as well to announce this new relationship with the EBRS, the Evidence-Based Reviews in Surgery, and the Global Surgery Foundation, which is hosted at the United Nations Institute of Training and Research here in Geneva, Switzerland. So from Vancouver through to Calgary, to Toronto, and to I think Cleveland, and to Geneva, Switzerland, and around the world, we welcome you and are very happy to start this webinar. So I will like to turn it over to Carl and Jason as our moderators, and look forward to hearing more about this interesting paper of doing surgery in the time of COVID, which has changed our world significantly. Thank you, Carl and Jason. Take it away.
So good morning, everybody. We at EBRS are extremely pleased and excited about this new collaboration, and we love the idea of bringing virtual journal clubs to everyone around the world. So welcome. We would like to start the session with a question for the audience. So we'll be running a series of questions in our audience polls. You'll have the ability to answer, and then we'll go through each answer after each question. So can we have the first slide, please? Okay. So for our first poll question, we'd like you to respond if COVID-19 has changed your surgical approach for abdominal procedures at all. Response 1, yes, I perform all my cases open now. Response 2, some cases that I usually perform laparoscopically, I am now doing open. Response 3, no, I'm following the same approach as I have before. And response 4, none of the above. Shall we show the responses to that or move on to the next question?
That's a technical issue. I'm not sure with the organizers whether they plan to show it immediately. Is that the plan, Julia?
We will go through the first 3 questions, and then we will show the answers immediately.
Okay, great. So if we can move to the second question as well. Laparoscopic surgery is associated with more smoke or plume than open surgery. If you could respond, how strongly you agree or disagree to that statement. Finally, for question 3, laparoscopic surgery is associated with an increased risk of COVID transmission compared to open surgery. Again, if you could respond, how strongly you agree or disagree to that statement. And then once we have a response, once we have the responses, we will show all the responses from the audience. We'll give it about 1 minute to get all your responses in, and then we'll show the responses. Okay, excellent. So we have responses from our audience participants. In terms of surgical approach, some people are favoring more open cases now. whereas some are following their previous routine. So I think it's a fairly even split between the options that were presented. Number two, in terms of opinions of whether we think laparoscopic surgery is associated with more smoke or plume than open surgery, I think there is some question about it, as they're mostly, the responses are mostly centered around neutral or agree or disagree, with no one really strongly agreeing or disagreeing with that statement. And with the statement that laparoscopic surgery is associated with an increased risk of COVID transmission, again, there is some differences in opinion, and we see a range across the board from agree to neutral to disagree and strongly disagree. So I think that shows the importance of a paper like this, and the discussion that's going to ensue is that the answers or what to do in this situation is not clear. And certainly the discussion, the education around that is important. So with that, I'd like to hand it over to Carl, Dr. Brown. Oh, Carl, you're on mute.
Can you hear me now?
Yes.
Great. At EBRS, we are incredibly excited about this partnership with Unitar, and I'm very excited about this webinar, and I'm grateful to all of our panelists for joining us this morning. For those of you who don't know, Evidence-Based Reviews in Surgery is an online platform. It's a free resource for surgeons who want to better understand critical thinking. We have panelists just like the ones we have here today who virtually review papers and provide those reviews online. Signing up is free at ebrs.online, and you can see the coronavirus paper that we're reviewing today has been reviewed by the panelists, and so you can go and find a very detailed and thoughtful review from each of the panelists about the methodology and clinical review of the papers. There are a number of papers in the archive as well, so I hope you'll take advantage of this free resource. So let's talk now about the COVID-19 pandemic. As you know, it's an infectious disease caused by severe acute respiratory syndrome, coronavirus 2, and it has spread around the globe and created a true crisis, both from a health perspective, an economic crisis, and we've seen many of our frontline healthcare workers putting themselves at risk to battle this disease. It's highly contagious compared to some of the more deadly diseases we've seen in the past. And because of the combination of contagious element as well as the mortality, it has really become a perfect storm of an infectious disease that can spread around the world, killing many patients. And as we've seen from the Italian data, on the front lines, healthcare workers are exposed to this. And this is a big part of why we're reviewing this paper today, because we want to make sure healthcare workers stay as safe as possible in the provision of this care. I do want to take a moment to remember all of the people who have contracted and died of this disease, including many frontline workers, including nurses and physicians, and reports recently of over 100 physicians dying in Italy in the process of treating patients under these circumstances. So when we think about surgery and COVID-19, there's a number of considerations. We want to find the sources of best evidence, and how do we do that in a crisis? We want to protect both patients and healthcare workers, as we've said, and how do we also manage our other patients that still need to have surgery despite our hospital restrictions in the COVID era. There's really not a lot of data. I share this one paper where a number of patients having elective surgery in China during the COVID era were identified postoperatively to have had asymptomatic COVID-19 at the time of elective surgery. Now, there weren't that many patients, 34 patients identified, and most were having fairly moderate difficulty, moderate risk surgeries, many of them for cancer. And alarming findings. About 60% of the patients were women, but 20% mortality in these patients. Now, you have to remember these were diagnosed post-operatively, but they did eliminate patients who seemed to develop COVID post-operatively. So again, in this asymptomatic patient population, very high risk of death. And of the patients that go to high ICU, nearly half of them die. We're going to cover a little bit in this webinar, sources of information in a crisis. Certainly journals have been a traditional source of information for all of us, but we know from Twitter, our friend Antonino Spinelli has shared a lot of information about their experiences in Italy, and we've relied on that through Twitter. The American College of Surgeons, SAGES, the Canadian Association of General Surgeons have all issued documents to help guide physicians for both patient safety and physician safety through this crisis. We also recognize this is an emotional disease. I mean, there are deniers of the virus and people who resist the current measures in place, all the way to the extremes of extreme fear of contracting the virus and going to extreme limits to try to protect themselves from contracting this disease. And certainly as physicians and clinicians, we're not immune to these types of concerns. We also know that there's a lot of proposed treatments for this disease or proposed associations. And as clinicians and critical thinkers, we have to be careful about taking these associations and assuming there's some version of treatment in them. And we know that without the evidence, we really are just opposing our opinions. But I do want to remind everyone that evidence-based surgery, evidence-based care and medicine is not simply the use of randomized controlled trials in the treatment of patients. It's really assimilating the best evidence available to try to give the best treatment that you can at the time. And in many cases, expert opinion is the best evidence we have available. And that's a lot of what we're going to discuss today, is how you integrate that evidence and how you move forward to try to provide best care. So I just want to introduce the paper and the panel that we have today. The paper we're reviewing is by Zheng and colleagues, which describes really recommendations from the experience in both China and Italy and how we might provide surgery, and specifically the potential concerns with laparoscopic surgery in this era. They posed really 9 lessons that were learned and recommendations for care, all of which are listed here and which we will discuss just in some detail with our panelists. We're very fortunate today to have our 3 expert reviewers. Dr. Sarah Moore works at the University of Toronto and St. Michael's Hospital as an outcomes researcher there. Dr. Sharon Stein is a surgeon who works at the University Hospital Cleveland Medical Center and is associate professor at Case Western University. And Dr. Chris Schlacht works at the University of Western Ontario and is the director of the C-STARS Minimally Invasive Care Center there. We're grateful to Dr. Ibbotson, Senior Health Advisor at the United Nations, and my colleague, Dr. Park, who's an assistant professor at the University of Manitoba, and myself, working at University of British Columbia. We'll try to moderate and help pose some questions. Certainly, if you have questions during the webinar, there is an opportunity to pose those, and we will try to share those with our reviewers. So without further ado, why don't we begin? I'll stop the share here, and we'll start with a question. Perhaps Dr. Moore, if you could weigh in. You did the methodologic review of this paper. This is really a clinical guideline for surgeons, and maybe you can just comment on what we would normally look for in a guideline like this, and perhaps where this falls in a crisis situation, how we might evaluate this guideline.
Sure. Thanks, Dr. Brown, for the introduction. So, I mean, as you alluded to in your presentation, we're calling this a set of guidelines, and that just makes it easier in terms of being able to evaluate a paper from a methodologic standpoint. But really, you know, and we should acknowledge the timeliness of the article, because most stakeholders, especially early in the attempts to mitigate the spread of the virus, have taken a respectful pause at the experiences a lot of these jurisdictions that saw early peaks. So it does behoove us to pay attention to the advice coming from these people who have gone before us. But really, if we're going to classify this, it's a highly, highly limited set of guidelines. We're classifying it as guidelines, but really it's, as you alluded to, Dr. Brown, it's advice from surgeons in 2 countries who at the time had seen the large-scale effects of COVID when many of us elsewhere in the world had not. So, I mean, when we're looking at guidelines, a good set of guidelines has to present the best available evidence. And it's critical that not only do they present the best available evidence, but how they arrived at that, at identifying the evidence and classifying that evidence. The members of the panel should be, there should be some overlying statement about who the members of the panel are in terms of, you know, are the people who generated the guidelines experts? What are they experts in? Do they come from a variety of different backgrounds that you can, you know, so that you're not just getting a one-sided view? You know, I said that this is basically a set of a list of items that are basically just considered advice. And unfortunately, while the authors of the paper have experience, they're not necessarily the experts in the field. In addition to that, the guidelines should be peer reviewed, and each item in a set of guidelines should be evaluated based on the weakness or the strength of that particular recommendation. So it's really lacking when you look at guidelines and how they're generated and how they're published and peer reviewed. This is really lacking, and I don't think the authors ever intended on this being a formal set of guidelines that we all have to abide by. The unfortunate thing, though, is that when you compare it to the SAGES guidelines, for instance, like there's a caveat in the SAGES guidelines that these are not a robust set of guidelines because the quality of evidence is poor. I think the recommendations that are presented in the article are reasonable, and I think a lot of it is kind of what we would view as largely common sense. And I was happy to see that they didn't come out and make the overall arching statement that, you know, laparoscopic surgery should be avoided completely. But you have a set of opinions that have been published in a high impact surgical paper, and when everyone has lots of information kind of flying at them from all different angles, when you have something like this published in a high impact paper, the reader may take that, may not necessarily take that with the grain of salt that they should be. So, you know, most guidelines will start with a systematic review or a meta-analysis of the literature present, and that's usually a springboard for guideline development. And obviously the best set of guidelines, if we could generate the best set of guidelines, it would be based on very high quality research such as RCTs or meta-analysis. And obviously we would go down the ladder from there until we arrive at expert opinion. And, you know, I think we've all seen sets of guidelines that are largely based on expert opinion. And that's useful because it allows us to see where the gaps in knowledge are. But as I alluded to, while this is an opinion based on experience, it's not necessarily expert opinion. The guidelines, you know, or the recommendations, I'll call them, would have been strengthened if there was opinions from not only, there were two surgeons and I think a methodologist or a researcher on the paper. It obviously would have been strengthened had you had not just general surgeons, but other types of surgeons who perform laparoscopic surgery. And in addition to that, perhaps even other people involved in the surgeries, anesthetists, nurses, et cetera. And probably most importantly, an infectious disease or virology expert. They really, you know, the whole backbone of this is based on not only on experience, but they make reference to a couple of studies that look at, that point out the prevalence of HIV, HPV, and Corynebacterium in surgical plume, and they kind of use that as their springboard to generate this paper. So it's you know, the backbone is pretty shaky for the set of recommendations, but I think, as we all acknowledge, there is a distinct lack of information and evidence-based information that we can draw on. And so really, at the time that these recommendations were published, it was kind of the best evidence, I guess, we had at the time. It just would have been nice to have the authors somewhere in the article say that, you know, by no means is this a true set of guidelines, and data is going to be constantly changing. It really, depending on who the reader is, like as I said earlier, and someone unfamiliar with methodology may not be able to take the recommendations with the grain of salt that they probably should be.
Yeah, it's really a list of recommendations based on personal experience and some supposition, certainly. Dr. Stein, maybe I ask you to jump in. So this created a pretty big furor in the general surgical world. Obviously, we're doing a lot of our surgeries laparoscopically now, and we've seen a variety of ways this has been taken up, all the way up to and including recommendations against doing laparoscopic surgery that were issued in the United Kingdom. Could you perhaps comment on how your institution integrated this paper and this communication, and what your impression has been among your colleagues in the US, especially in the northeastern US, where there has been a pretty serious problem with COVID? You're on mute, Dr. Stein.
Thanks. Well, I got to remember how to use Zoom, right? One of the things I think is really important is, I think this article was so important because it brought the conversation to all of us. And if I look at the way that general surgeons have looked at this conversation versus some of my colleagues who, in gyne, onc, or in urology, I think that this really brought it to the forefront. And for that, I think was a really important move. I think when you're thinking about how to do this, whether it's my institution, and in Cleveland, we've been extraordinarily lucky in not having a huge surge of COVID patients. It's really important to look at it in your own local environment. And I think, again, this article really brought attention to the fact that we have to look at both, in some places you're not doing surgery at all because of how bad the surge was. In other places, you're able to do surgery, and now you can kind of think critically, okay, both what are the benefits to this patient, and also what are the benefits or risks to the personnel in the room. And I think that that was one of the really important things that this brought to light. In terms of that, for instance, if you're doing a right colectomy in a skinny patient, it may be that by the time you extract a large tumor, your size of extraction is about the same as it would be laparoscopically. And so the benefit, risk benefit ratio there may be very different than if you're doing a paraesophageal hernia or something like that, and you're going to end up with a thoraco-abdominal incision. And so I think that's one important component. In my own institution, what actually happened was when we I obviously spent a lot of time thinking about this, thinking about what we need to do. I went to my own institution and I said, which of this equipment do we have? What do we have to protect our personnel in the room? And there are two methodologies for that. One is, what do we do for personal protection? Whether or not you're wearing a 95 mask when you're doing minimally invasive surgery. And then the second piece is, what equipment did we actually have in the room, and what was the capacity of that equipment potentially to filter the virus? And the fact is, at this time, despite the fact that this was built, as Dr. Moore said, on pieces of virology that have come from other disease processes, we don't know whether or not the virus is infective in the peritoneum, in the blood, in the aerosolization, in the smoke. And so if we're trying to protect our personnel, we have to make thoughtful decisions, assuming that maybe there is some risk, and the fact that so many healthcare workers have been affected, perhaps there is some risk, and making the best decisions. And that means, rather than just opening up your insufflation or opening up at the end as a colorectal surgeon, I have to extract a specimen, and I'm often open up into a into fully pneumoperitonealized cavity, and all the air comes out, and that makes it safer away from the rest of the bowel. But now I can be thoughtful about my decisions in order to evacuate that pneumoperitoneum early in the case, before we make that incision, that I can make sure that we have appropriate filtration devices, and that we can have a nice conversation with the people in the room, telling them, I don't know whether or not the plume is going to be, has virus in it or not. And I think the other thing that's really important, and my evaluation of this has brought to the forefront, is that in some ways, when we do minimally invasive surgery, perhaps the plume is actually better contained, and perhaps we actually have a better control over whether or not that gets into the room. We all know when we do open surgery and you create a plume of smoke, you can smell it, you can, despite the fact that we now have smoke evacuators, they're not always very successful. And silly things like the fact that when you actually use the suction to get rid of some of that extra smoke, some of those suction machines are not going to ultrafiltration devices and actually release that same smoke, whether you're open or laparoscopic, right into the room. And I think the really important parts, again, are that we can be thoughtful about what we need to do, and we can look at whether or not we have the equipment to try to keep our personnel safe.
So same question for you, Dr. Schlachta. I mean, how have you integrated this data at your institution? I suspect, like many of us, you get questions from other institutions about what they should do at their site. How did you integrate this data, and what are you doing for MIS cases?
Yeah, thanks, Carl. I would echo a lot of the comments that Dr. Stein just offered. I was on another SAGES webinar last week, and I'll paraphrase Gretchen Jackson's comment. Her talk was, when are we going to get back to normal? The answer is we're not. And she tried to make the point that the coronavirus pandemic is actually accelerating a lot of change that was already underway. And I would suggest in some ways it's probably making us more conscious of what should have been standard of practice to begin with. So we had all of the mechanism in our operating room to contain the smoke plume for all of the reasons why we should do that. You know, concerns about toxic chemicals and organic matter and so on. So when we headed into this pandemic and said, now we're gonna, what do we do with the, you know, potential coronavirus patients in this setting? I think it just made us more diligent about controlling the smoke plume. So without repeating all the comments that Dr. Stein has offered, you know, I think that you have to think about what's the value of a laparoscopic approach in your individual patient. I also think, you know, I've heard of centers that have said, we're going to stop doing laparoscopic surgery. I would remind everyone, first of all of this is personal opinion and nobody really knows the answer. I would remind everyone that it's a theoretical risk. And I think the precautionary principle dictates that we should, for the time being, assume that there's potentially live virus there, although we don't know that for sure by any means. I actually think it's probably unlikely that there's live virus in there, but we should be careful until we know for sure. So we filter the smoke that comes out of the abdomen. I have not reduced my practice laparoscopically in any way, but I've taken all the precautions that have already been mentioned. I think that I've often walked into the OR or been in an OR doing open surgery when there's so much smoke in the room that you have to wonder what the concern about laparoscopic surgery is, because I think we actually control it better laparoscopically. But I think you have to ask some important questions. Do you have a filter that is capable of filtering out the virus particles? Most of the filtration systems are better than an N95 mask. So as long as you're using that effectively, then you're doing the right thing. You know, when it comes time to extract, we do all of our rites totally intracorporeal, but certainly sigmoid and everything else. When it comes time to extract, you know, in the old day, you just open up the valve and let the gas out. So now we make sure that we either vent all of the gas through one of those filtration systems or we suck it out. But if you're going to do that, as has been mentioned, make sure your suction device isn't just blowing that gas back into the room or somewhere else in the hospital. You know, just take those precautions. We are not currently testing all of our patients preoperatively. They get screened. And if they screen negative, then we treat them as suspected coronavirus, and we all wear full enhanced PPE in the operating room, including face shields and masks and so on, which uses up a lot of PPE. And it's kind of frustrating trying to, you know, it does, I think, compromise our vision a little bit. But I think that's the best you can do. But I think the most important lesson we're learning from this, you know, we have our own review on this, as many have written on it. Our fellow Dr. Vertsumis will soon be coming out with a paper where he's reviewed the risks of smoke plume and said, I can't believe we're doing anything differently now than we were doing before. We should be treating these smoke plumes as dangerous, toxic smoke plume. The virus is probably the least of our concerns. So there's lots more in that paper, but I'll pause at that point.
Great. I think that raises a lot of questions. I mean, we adopted the ultrafiltration after this paper, after these considerations came up. We didn't have them in advance like you did. And I'd be curious, I saw Dr. Moore nodding, are you using those same techniques? And just by, I guess, nod or shake head no, is everybody using PPE for every case now? Yeah, we aren't. And I'll come back to that. But perhaps Dr. Moore, you could comment what you're doing at the University of Toronto right now.
So it depends on where in the city you are. There's a number of hospitals in the city, and whether or not you're on one side of the street or the other depends on what people have been doing for laparoscopic surgery. At St. Michael's, we basically stopped doing it for a number of weeks. And I've had patients refuse their cancer operations because they can't have them laparoscopically. But we've been like especially stringent on just elective cases in general. Like we were holding cancer operations for at least a week or two during this period. And even now we're taking on a case-by-case basis, and OR time is allocated 7 days in advance to every service. So it's a highly regimented procedure in terms of case selection, but we weren't doing laparoscopic surgery, and that includes for appendectomies and cholecystectomies. Obviously, we were doing sort of a combination between what made sense for our institution and also based on the ACS recommendations for acute care surgery. But certainly in the elective setting, we weren't allowed. And it's only this week that we're starting to do laparoscopic cases again. And a big reason is, whereas Toronto Western Hospital, which is, 500 meters down the street, they continued doing laparoscopic cases because they just had, these unique filtration systems available in their hospital, and we just didn't, unfortunately. And then as we were sort of talking about this as a division, there were also comments like, well, even if we had the filtration system, a lot of our valves are quite leaky anyway. And so some of our equipment probably needs a bit of updating. And so that also weighed into the decision to cease doing laparoscopic surgeries. But it's had a tremendous impact, I have to say, especially when, Dr. Stein was talking about a lot of our cancer patients are elderly and comorbid, and really this has nothing to do with cosmesis. It has everything to do with getting them out of hospital as soon as possible. And I think when we're looking at a lot of the ERAS papers, like we know that laparoscopic surgery only really saves 1 or 2 days in hospital, but for some reason, anecdotally, it just feels like people just do better when you can do a nice laparoscopic cancer surgery, especially the elderly patients. So it's been quite practice changing in the short term for us.
Perhaps Dr. Park, you could weigh in as well. What have you seen at your center?
Sorry, just before I answer that, we do have a question and answer panel open for any audience members. So if there's any audience members who have any questions, you can insert them into the question and answer panel, and then I'll go through them and then present them to the panelists. So that box is open for you. I think we've done a lot of the things that what has already been discussed. What's interesting about this entire process is how much things changed almost on a day-by-day or a week-by-week basis. So the memorandums that we get change almost weekly. And we've gone, I would say, full spectrum in some ways of going from, everything's canceled, we're preserving everything, to, we don't have enough PPEs, to we're going to start letting things go. And it's cycling back and forth somewhat. And I think a lot of the discussion that's come up about what things are like locally, what your resources are, what the urgency is of the cases, all of those considerations have to be taken into account before you can make recommendations. And that's why I think these discussions are so important. Is I think it is a moving target. I think it changes, and what it might be in 1 week is different compared to how it may be in a second week. Currently, we are trying to, for our emergency cases, we're going with full PPE. We're also going for, after the anesthesiologist, so the anesthesiologists have a strict protocol on how induction is done. It's the anesthesiologist, one assistant, and usually one nurse in the room at that time. And then everybody leaves for 20 minutes to clear the air in the room. And then we all re-enter, and we do that at the beginning and at the end of the case. So it's added a lot of time to each of our emergency cases. For elective cases, we've asked people to self-quarantine if they're looking forward to or about to being considered for a procedure. And if they've been self-quarantined for 14 days and have no symptoms, we've been more lenient on the protocols. What's coming down the road, what we've been informed from our region, is that there will be testing available, so that if people have no symptoms for 14 days after self-isolation and they have a negative test, then we can go, or more likely be confident that they're unlikely to have COVID, and go ahead with surgery without PPE. Part of the goal of that is trying to preserve our PPE. So again, I think what we're doing week by week has changed depending on resources, acuity.
And perhaps Dr. Stein, if you could weigh in as well, what you do for your patients. Do you follow that same intubation pattern for all patients? Are you universally testing patients? And I know you have some experience in your training in New York. I'd be curious if you've had much communication with your colleagues there and if they're doing anything differently. And we've had a question as well from the audience about what specifically we mean by PPE. So if you could just be clear about what you are using at your site.
So I think it's very varied. One of the things I found when I went to go do my first, so for a while we had all non-cancer, elective surgery canceled. And when I had a patient, I didn't have anybody who I felt like needed laparoscopic surgery for a little bit. And then when I had my first laparoscopic surgery, it was actually a couple weeks later. And I realized when I went to the control desk and asked them what exactly we had and what exactly the filtration devices were, that nobody else had really been asking those questions. And that's what I was saying about kind of urology and gynonc had been doing surgeries. And some of our surgeons had stopped doing them, but nobody really was looking at our filtration devices. And so I think that's one of the things about the local environment is really knowing that. In terms of PPE, it's also quite varied. I'm still doing cases with TB mask, a N95 TB mask, and then a face shield. I feel like I have an elderly, I think everyone has their own personal story, right? I have an elderly family member who lives with us, and I know that I'm going to be high risk. And so anything I can do to prevent bringing that home is worth it for me. When I did a laparoscopic surgery just last week, I talked to the entire staff at the beginning of the procedure, and I said, we don't know what the data is. We don't know if this is more infective. There's concern that it could be. You should make your own decision about whether or not you want to wear an N95 mask. Most of the people who aren't in front are not wearing face shields at this point. So it's real varied. It's real all over the place. And there hasn't been a institutional demographic kind of statement about what we should or shouldn't be doing in terms of that. I also think this gives us a great opportunity to really think, as Dr. Shalata said, that we can kind of think about how we do things and move things forward. I know University of Chicago came up with a COVID consent form where they're telling patients about their increased risk of morbidity if they were to turn positive after the surgery, where they're telling patients they may not have visitors allowed for the duration of their procedure, that they may not go back to the operating room in a timely manner, even if that's indicated. And I think this really gives us an opportunity to kind of look at how we consent patients, how we talk to our staff, and to make the best possible decisions.
Same question, Dr. Schlachta, and maybe just comment as well on the screening for patients. Has anyone here operated on a known COVID positive patient?
So I have the luxury of working in a 1,000 bed hospital where I think our peak number of admitted coronavirus patients was 30. So we are not facing the same challenges that so many of our colleagues around the world have been facing. However, this paper, for example, was 3 or 4 weeks ago that we first saw this, right at the very beginning of all of this. And I think most of us have taken the same approach, which is to react aggressively, and then we can start backing off as necessary. So like everybody else, we canceled all elective surgeries. We've been pretty much operating on the basis of the only patients who are getting surgery now are either emergency cases or patients who would come to harm if they didn't have surgery within 7 days. And we've been doing that for 3 weeks now. So that begs the question about when we now start allowing patients to have surgery who would come to harm if they didn't have their surgery within a month, for example. We're screening the patients with a simple questionnaire about symptoms. We keep expanding that questionnaire to include new information that's coming forward about abdominal symptoms and anosmia and all those new things that we're learning about the coronavirus. Our PPE, the only patients where we don't wear full PPE is if they have been tested within 24 hours and are negative. And they're doing that, for example, on transplant patients. Otherwise, I'm wearing an N95 mask. And because of shortages, we only have the 8210 mask, which is not apparently certified for a direct hit with blood. So we wear a second surgical mask over the 8210 N95 mask. We also wear a visor, a bouffant cap that covers the ears. Like, we're really packaged up in the spacesuit for the surgery. We'd all love to see that easing soon, but that's what we've been doing for the time being.
It's interesting, whenever we institute these, there's always a desire to be the safest possible, but we do know with PPE shortages that a full operating room or even a partial operating room running at full PPE precautions really taxes our resources at the institution. And so we have to be very thoughtful about that. At our institution, we have not been using full PPE. We're doing the anesthesia protocol that you described, or that everyone has described, with the delay, with the negative pressure rooms circulating and hopefully clearing the virus. if there is a virus there. But we have controversially started doing universal testing for both elective surgery patients. We didn't stop doing elective surgery. Anything that was surgery within a month urgency, we have continued through this. And as others have mentioned, we've had a relatively low volume of patients at our institution with COVID or with coronavirus. And so we have been fortunate to maintain that. And we've done some modeling. It's going to be a disaster trying to catch up with those patients if we don't start doing cancer patients soon at some of our institutions, if those have stopped. So, but I do want to touch on this universal testing. I must say, as a physician in the operating room, and also I would say that our OR team, the nurses, the anesthetists, they're all well aware of these issues now. They know some of the controversies associated with laparoscopic surgery. So for us, certainly there is a psychological benefit to having a COVID negative test, as was highlighted in a patient that we're doing surgery on. But, you know, there is a question about whether that's the best use of that testing. It sounds like nobody else is doing universal testing for surgical patients. Is that right?
We're supposed to start, May 1st, we're supposed to open up to elective surgery, and the plan is to do universal testing. One of the issues with that is that universal testing isn't perfect, you know, and there's certainly any of these tests, depending on which one you pick, has a, you know, negative predictive value. And so I think you still have to do what you think is safe and best practice, even with a negative test.
If you don't mind my jumping in there, Carl, I completely agree with that. The negative predictive value, like, it depends on what the prevalence in your population is, right? So if you've only got a 2 or 3% prevalence in the population, you've already got a negative predictive value of 98% by just not testing anybody. And then what are you adding by testing when there might be as much as a 30% you know, false positive or false negative rate, right? Now, can that get you closer to 99 or 99.9? I think it can. And I think there's a lot of psychological security that comes from testing, but you know, there's a lot of challenges with testing. We're not testing everybody. I'm told the main reason is because we just don't have the tests available.
I know that there are other,
sorry, go ahead, Dr. Stein.
There are other places where they're doing 2 negative tests, and then you're asking people to quarantine as well. And as we all know, people sometimes come in eating and drinking when they're supposed to have been NPO. What is the likelihood that they're truly quarantining during that time? And so I completely agree. I think that the negative test doesn't necessarily make me feel better. I think if I was in New York, it wouldn't make me feel any better about it. And here it doesn't make me feel any kind of worse to operate on somebody without a test.
I asked Dr. Moore to look into the test characteristics. Could you comment on that?
Yeah, so I mean, obviously this is probably the biggest issue with COVID right now. And I've looked at a lot of studies and we just do not have reliable test performance characteristics. And largely because we just don't have a gold standard test. So like, it's interesting when you look at some of these studies, like a lot of the ones out of China are like the earlier ones are comparing like CTs to PCRs, but the problem is that depending on the study you're looking at, like they're basically comparing it to patients who have had like 2 or 3 negative PCRs in order to classify them as negative, or patients who were confirmed positive had to have had at least two positive PCR tests to confirm that they were positive or whatever. So that you avoid the uncertainty of those who had had an initial false negative test. And, you know, it depends on the study you look at, but there's a, you know, not super reliable systematic review that's available in preprint. And they looked at a number of studies and they selected 5. And basically they're comparing false negatives, and they say it ranges depending on the study, and there's a huge amount of heterogeneity in the studies. And that's just the study. The test itself, there's a huge amount of heterogeneity because the sensitivity of testing depends on the assay you're using, and that varies worldwide, and sometimes it varies from jurisdiction to jurisdiction. The type of specimen you obtain, whether or not it's bronchoalveolar lavage testing, which is shown to have the highest the lowest, I guess, false negative rates versus sputum testing. And then nasopharyngeal swabs are actually quite a bit lower than BAL tests. The quality of the specimen, and then there are some studies to show that the duration of illness, like how many days into your disease, how that will affect the false negative test result. So you really can't say what the sensitivity of the test is at all. And it's also important to know that a lot of these studies are looking at people who are in critical care settings or people who are hospitalized. And now we're talking about what's the utility of universal testing. There's a really nice summary that is in preprint, and it's going to be published in Mayo Clinic Proceedings. And they actually go through a number of scenarios about, based on what the infection rate is, based on what the assumed sensitivity of the test is. I'll just give a couple of examples because it was really interesting to read. And so they say, if they're, for example, in the state of California, they're estimating that the COVID-19 rate may exceed 50% by mid-May. And they say at the population of 40 million people, 2 million false negative tests would be expected with comprehensive testing. And even if they only test 1% of the population, you're still getting 20,000 false negative test results. So obviously we're all reassured about a status of a patient when they have a positive test, because then we know what to do. But, what is the utility in doing one NP swab that has, a false negative rate upwards of 30% associated with it? And that's very high. Are we going to test them again? And is that enough to reassure? And so with all those patients, are we going to abandon use of PPE? It's really difficult to know what to do in the surgical setting. And I personally don't really see the value in universal testing because of the huge amount of uncertainty around how well the test performs. As I alluded to earlier, that's just the PCR itself. And there's so many other patient-specific and tester-specific factors that go into how reliable these tests are. So, I think the screening is important, and I'm sure that every hospital is screening their patients based on what the WHO recommends in terms of screening questions. It's just, I don't really personally see the utility in universally testing patients for all of the reasons that Dr. Stein just described. Does it make us feel more comfortable? Probably not. I mean, I just sort of feel like COVID is kind of floating around all of us right now. And I don't know if a negative test result makes me feel any better.
Just a comment from the Portuguese Institute of Oncology. One of our online observers is saying that they are doing universal testing now, and to date they haven't had any surprise post-operative tests. Obviously their rates are perhaps higher than we're seeing in much of Canada and parts of the United States as well. I wonder, as clinician researchers, what the appetite would be in this sort of crisis era to subject your patients and subject your teams really to some kind of trial or a cluster randomized trial. Would you be willing to be in a group where if there was a negative test that people would do no PPEs? Maybe I'll start with Dr. Park and go around the table and see if people would be willing to enroll their institution in some kind of lessening of PPE.
I think it's an interesting question. I think, so we had another audience, actually an audience member from Portugal as well, ask about commenting that there's some resemblance of what's going on now with the laparoscopic port metastasis myth, is what the wording is used, and whether there's any analogies to that. And I think that speaks to dissemination of information when data is really limited and how the community reacts to that. And I would actually like to see the panel members' responses to that, of how do you safeguard the reactions or how you respond to pretty limited reports. I think it's an important issue. Would I participate in a randomized study? That's a good question. The short answer is I'd have to think about it. I think it's a very reasonable question, and I don't think anyone knows the answers. Do I think there's equipoise, that both options are reasonable? I don't know that we have enough information to really push that.
Dr. Stein?
I would second. I don't think we have equipoise to really do that. And I think that there's a significant component of people's emotional wellness in this whole thing. I'm really concerned about our profession, and not just as doctors, but as healthcare providers in any way, shape, or form. At the end of this, how we're going to be doing about feeling about our own autonomy, or about our own wellness, about our ability to make decisions, because there's so many different situations that are going on, and whether you're in New York City or Italy where things have been really bad, or away from that and you're doing a bunch of things that aren't really asked of you normally, including homeschooling, you know, all of that. So I think their ability to make their decisions to some extent about PPE is actually an important one. I also think the other flip side of that is that for our patients, I think some of that data that says that there's a 20% or higher mortality rate if you are positive after your surgery, maybe the reason for testing is really about our patients and to give them some sense of you know, kind of autonomy or control over the situation, because I think that that is probably equally as important as well.
Dr. Schlagman?
If I understood the question correctly, you're asking if we would be willing to participate in a trial where we didn't wear enhanced PPE and see if we get coronavirus as a result of that. I think the answer to that
in
one
a test negative patient, in a test negative patient.
In a tested negative patient. Well, even so, we still know that there's a high false negative rate. So in a world where I'm still lining up for a half an hour down the street waiting to get into the grocery store right now, and that businesses have all been shut down because of social distancing, I think it would probably be premature right now to conduct that kind of a trial. You know, healthcare workers have been identified as being at higher than average risk for contracting coronavirus. And we're also being seen as one of the primary vectors for dissemination of the coronavirus as well. So I think for the time being, we have to probably be as cautious as we can. And, you know, but I would participate in other trials, like trying to isolate live virus from the smoke plume, for example. That's something that if we could study that, we could determine whether the hysteria about laparoscopic smoke plume is really a thing or not. I suggest not, but again, clearly personal opinion, take precautions.
Dr. Moore, would you participate in that trial?
It's interesting because we don't, it's actually very strange, but we don't use PPE for COVID negative. So unless someone is like a person under investigation where everyone in the OR would behave as though that patient has COVID, or obviously if a patient does have COVID where everyone's wearing PPE. In the non-tested or, you know, negative, like patients who have had a negative screen, no one else in the OR, with the exception of the anesthesia team, is wearing full PPE precautions. I'm not exactly sure why. I think a lot of it is just because of, I mean, we're in a bit of a weird situation where, like, we don't have a ton of cases. Right now we have, today I think we have about 30 cases in our hospitals, probably has about, I don't know, 300, 400 beds or so, and 35 patients under investigation. But the problem is that there's a lot of cases in Ontario, and so patients are getting shipped from all over the place, whether or not they have COVID. So, you know, there's been a big push to conserve PPE equipment, and so us as surgeons aren't really wearing N95 masks or face shields or anything like that. So I don't know. I could be your N of one sample.
Well, I can say it seems that maybe we are in this trial because at our center, we're not using PPEs in COVID negative patients either, except for the anesthetist. So Dr. Moore and I have both been randomized to no PPEs.
Yeah.
Dr. Hein has left a comment that the viral load may be too low to detect in asymptomatic people, in the pre-symptomatic phase, so they're not doing universal testing either. I'm assuming that's Dr. Hein from Calgary.
Dr. Schlagman clearly wouldn't be randomized. He won't even go to the webinar without his PPE on apparently.
No, well, actually, I don't necessarily agree with our policy. Because, you know, there's a lot of personal opinion and a lot of, but I'm going back to the OR in a few minutes, and I'm doing a laparoscopic right colectomy, and I'm going to wear an N95 and a mask and a shield. I mean, it's, you know, it's hard to breathe for that long, you know.
So I see we have about 5 minutes left on the webinar, and I did want to address one issue, which I think even Dr. Moore alluded to this, because you know, where you find resources in this kind of era, waiting for a journal publication is not ideal. I mean, even though, you know, we have to commend Annals of Surgery and other journals who have rushed things to publication. What are the other sources? I mean, medRxiv is a partnership of Yale and the British Medical Journal, which pre-printed papers can be submitted, and there's a good paper there on the expected enhanced mortality of cancer patients after or during the COVID era because of delays to surgery. So you can actually get access to papers before they're published in a formal journal, of course, with the caveat of no peer review. So that Twitter, I mean, can you just sort of comment on what resources you've been using as well, in addition to traditional journal resources? Maybe Dr. Park, I'll start with you.
You know, it's a good question. It's actually one of our poll questions coming up at the end for the audience, and what sources that they've been using. I think I've been using a multitude of sources. I've been using my everyday news media sources just to get a sense of the numbers in our area. I've been reading a lot in the Annals of Surgery, of the articles coming through, and I've been paying pretty close guidelines to major organizational guidelines like ACS. One of the questions that I have, and it's related to a poll question, is the quality of what's being published right now. I think with the desire to get information out quickly, I'm seeing some papers published in journals that I think under normal circumstances wouldn't necessarily be published without better review or higher levels of review. And I think those pose difficult situations if we're trying to move forward with evidence based on or move forward with practice based on lower qualities of evidence. I'd like to hear the panel members' comments on that. Maybe Dr. Stein, I saw you nodding on that comment.
Yeah, no, I think that the problem, and Dr. Moore alluded to this, is that once it gets published in a high quality journal, people take that as truth, whether or not it's actually evidence-based. And I think the problem is that we're so hungry for information and we're so hungry for data that any small amount of data gets published, whether or not that's true or false. I will say that I go to a lot of my societies, both their webinars and also, to their websites in order to look for information. SAGES has a great one. ASCRS has put on a lot of different information. I also have been, especially in the beginning, I was looking at Twitter kind of insatiably. I followed Dr. Brown, which is how I got roped into doing this, right? So I go to people that I know or that I believe and who seem to have more information or more experience in this situation and kind of look at what they're doing. I'm also talking to friends, but then I think you have to take everything you hear with a bit of a grain of salt and then kind of step back and really think about it critically and take some time to figure out whether it's true. But I think the problem is that we won't have the answers we really want and need until after this wave at least is kind of over. And then hopefully for the next time we have something similar, we're going to be better prepared and may have some more information.
Yeah, the rumor mill really grinds during this time for sure, even in medicine. Dr. Schlachta, could you comment on that as well?
Yeah, well, I think that in retrospect, we're going to look back at a lot of the papers that were published even in high impact journals, and we're going to say, how did that get published? Because it doesn't stand up to our normal methodological rigor. I think we all agree on that. But it's got to be counterbalanced by the urgent need to disseminate information rapidly. And that's why people need, to understand how to critically appraise the literature themselves, so they know when they're reading an article, just because it was published in the New England Journal doesn't necessarily mean that it meets their current standard in the interest of getting the word out. But I think we've already covered all of the other avenues that are available. And, surgical societies have all stepped up. And, my primary society right now is SAGES, and they have a COVID resources webpage. I've had the luxury of participating on a weekly global surgery Zoom call with surgeons from Italy and Spain and South Korea and the UK. And all those notes are in our notes from the battlefield section. And, the first time I heard about anosmia was 3 weeks ago from the Spanish surgeons. And they were the same ones who said that if you're consulting on a patient in the emergency room who's got abdominal pain and they're getting a CT scan, make sure they get their chest scanned at the same time, because there was this interesting phenomenon that some COVID patients were presenting with GI symptoms as their primary presentation. Not the majority, but some of them. So you learn these things anecdotally, and you try to adopt precautionary measures into your practice based on those anecdotes. And you have to appreciate that none of it is really solidly evidence-based. So you make judgments. But surgical societies, I think, I appreciate the literature, but we all know that even if you're going to publish almost anything, there's still a lag. The surgical societies, I think, have all really stepped up and tried to be there for their members and provide ongoing education and support, which I think has been demonstrated a lot of value.
Yeah, it's been a real boon to have such easy access to information and dedicated clinician leaders at all those organizations willing to put in the time to put those guidelines out to help us. So it's been fantastic. I see we have about a minute left. I just wanted, there's poll questions to finish with. Is there, Jason, or?
Yeah, we have some poll questions. If the audience, and first we'd like to thank the audience members for their participation. We're putting up some poll questions now based on some of our discussion. If the audience can respond, and then we'll go through the answers afterwards. So first, the question is, are you making any changes to your laparoscopic abdominal cases due to COVID? No. I'm using lower pneumoperineum pressures. I'm using a filtration system to evacuate all the pneumoperineum at the end, or you've stopped doing laparoscopic cases, or some other changes. The second question, or after going through the paper and some of this discussion, the comments on whether you feel that the recommendations in this paper are supported by evidence, whether you strongly agree, disagree, or strongly disagree with that comment. And we'll give you about 30 seconds perhaps, and then we'll look at the responses. Okay, so to look at the responses, I think that's what we've discussed, and I think it actually came up several times, is in the most popular response, or the most common response, is using a filtration system at the end of the case to evacuate all the pneumoperineum. So certainly when I started seeing the literature coming out on that, I made a particular effort of positioning the patient, trying to get my filtration port at the highest point and trying to evacuate as much of the pneumoperineum that way before opening. And it looks like that's a fairly common practice. Whether we feel that the recommendations in this paper are supported by the evidence, the feeling from the audience members was neutral. I think that's a reasonable response. I think it'd be somewhere between an agree and a neutral for me, but you can see that there is some discrepancy in how people feel about that one. We do have one other set of questions, short set of questions, if people are available. And we'll put up that poll. So the question is something that we've alluded to as well, whether medical publication should be held to the same standards in peer review during a pandemic compared to non-pandemic times. How strongly or you agree or disagree with that statement. And the last question is asking the audience members where they get most of their COVID-related surgery information. The options include major organizational websites like the American College of Surgeons, ASCRS, SAGES, medical journals, traditional news media, Twitter, or other. We'll give you about 15-30 seconds for that one, and then show the responses again. So there is some discrepancy in responses, but most people feel that the same standard should be applied to medical publications as during non-pandemic conditions. But some people felt that there would be some allowed leniency during that period. In terms of where people get most of their information, the strongest response, or the greatest number of responses, is for major organizational websites. Number 2 was Twitter.
I get all my information from Dr. Stein's Twitter feed.
Maybe you should put our Twitter feeds underneath here instead of our names next time.
Yeah, maybe.
We could. Well, we'll certainly have the information available afterwards. For people who are interested and couldn't make this webinar, we'll have recordings and a link available from the EBRS website as well. One final poll question for the audience members, and I think that Dr. Brown would like to conclude and do thank yous after that. For audience members, we'd just like to see which geographic region they are from. If you wouldn't mind just filling in that poll for our own information. Again, we are super excited to make this such a broad and far-reaching event.
Yeah, I think we'll wrap up there. Again, it's been just over an hour. I want to thank our panelists, Dr. Stein, Dr. Moore, and Dr. Schlachta, for their very thoughtful commentary on the paper and on how they manage patients in this COVID era. I want to personally thank Dr. Ibbotson and the UNITAR group for expanding the reach of evidence-based reviews in surgery, and I want to thank my co-moderator, Dr. Park, for helping make this a really great event. And as was mentioned, it will be available online for your viewing later, and we hope to hold more of these in the future. So again, so everybody stay safe, and we'll talk to you in the future.
Well, thank you very much, Carl, and your whole team. This has been a real pleasure on behalf of the United Nations and United Nations Institute of Training and Research and the Global Surgery Foundation. Thank you for this very interesting discussion. I find that, you know, the whole discussion is about the safety of our surgical team, but I'm really quite interested in that one paper you showed at the very beginning, Carl, about the impact it has on our patients. So I would really challenge us to go back, and there's two sides of the story. What's good for us and our teams and the people we're responsible for, but also our patients, because what a difference in mortality on patients that come in positive and we don't even know it. So great session. Really want to thank you guys, and I look forward to the next time, and have a great evening and day wherever you are in the world. Thank you very much.
Great, thank you.